Early cancers rely on androgens to grow, but as they evolve, they can survive even in low testosterone environments. And that's why advanced cancers often become castration resistant. And here's something most people don't know. Many prostate cancers grow so slowly, they will never take a man's life. You will die of other causes before you die of prostate cancer.
What's up, guys? Welcome to the Hormones Happen podcast. This is a podcast for men and women like you who know the care we receive is dictated by greedy pharmaceutical and unethical insurance companies that want to keep us sick and dependent on the system. Screw that. I'm here to educate you on the amazing benefits of hormone replacement therapy while dispelling the bullshit lies created by the fake news in the media. I'm your host, Jeremiah, and I'm a nurse practitioner who owns and operates an HRT clinic. I've seen firsthand the neglect and lies told to men and women like yourself to prevent them from taking control of their health. Together, we can create a better future for people like us. Join me in the fight for your hormones.
Welcome back, guys, to another episode of Hormones Happen. I hear it all the time. I'm sure you hear it all the time. Testosterone causes prostate cancer. Today, we're tackling a question that keeps countless men up at night. Does testosterone fuel prostate cancer? Well, for decades, doctors, patients, and let's be honest, even some researchers believed that testosterone replacement therapy was like pouring gasoline on a smoldering fire. But evidence has evolved. Today, you're going to hear the story of how this belief began, why it persisted, and what the evidence really says. So sit back and let's unpack the truth. Our story starts in the 1940s, when two scientists, Huggins and Hodges, made a discovery that would change medicine. They found that removing testosterone through castration or androgen deprivation therapy shrank advanced prostate cancer tumors. It seems simple. Less testosterone equals smaller tumors. So more testosterone equals tumor growth. This became the rule, the law for decades. If you were a man with prostate cancer, or even if you were just worried, you were told to avoid testosterone at all costs. But here's the twist. That early research was conducted in men who already had advanced metastatic disease. These were cancers that had already learned to live and grow off androgens, like testosterone and DHT. Yet somehow, this idea spread beyond advanced cancer into everyday practice. Even healthy men with low testosterone were warned away from treatment. Fast forward to the early 2000s, entered Dr. Abraham Morgentaler, a Harvard urologist who began to question that narrative. He noticed something was odd, something was strange. When he measured testosterone levels in men newly diagnosed with prostate cancer, many of them actually had low testosterone, not high. But how could this be? It led to a revolutionary idea called the saturation model. Imagine your prostate cells as glasses of water. Pouring testosterone will fill them up, but only to the brim. Once they're full, any extra testosterone that spills over the edge will have no further effect. Scientifically, this happens because androgen receptors get saturated, and that saturation point is around a testosterone level of about 250 to 350 nanograms per deciliter, which is clinically low. Above that point, more testosterone doesn't fuel more growth. This was the beginning of the end for the testosterone equals cancer myth. Let's zoom out and look at the big picture. Multiple large studies and reviews over the last 20 years have confirmed a couple things. Testosterone therapy does not increase the risk of prostate cancer in men with normal prostates. In controlled trials, men receiving testosterone replacement therapy may see a modest rise in PSA, roughly between 0.3 and 0.5 points, but this stabilizes over time. And I have seen this firsthand in several of my patients. The key word here being stabilizes over time. We've seen even after prostate cancer treatment, some men can safely use testosterone under specialist care. For example, a 2023 review published in the New England Journal of Medicine followed over 20,000 men on testosterone replacement. The result? No increased risk of aggressive prostate cancer. And even the European Association of Urology now states clearly testosterone therapy is not contraindicated in men without active prostate cancer and can be considered with proper monitoring. This is profound stuff, guys. We're changing our ideologies on testosterone.
If you're serious about optimizing your health, don't stop here. Visit stillcity-trt.com for in-depth information on all things HRT and TRT. Now let's get back to the show.
If you start testosterone therapy, what should you expect? Well, let's walk through it step by step. Prostate size may increase modestly, about 12% on average. And while this may sound dramatic, in most men, it doesn't cause symptoms. PSA may rise slightly as your prostate re-enters a healthy, what we call eugonadal state. But this is normal. What matters is the rate of change, not the absolute number. And for those unfamiliar, PSA, prostate-specific antigen, is a protein that's released by the prostate gland. We use it as a screening tool for prostate cancer. The reality is, 99% of it gets excreted in ejaculate, with only roughly 1% getting diffused back into the blood. Not to mention, there are a lot of things that can cause a false elevation, such as ejaculation prior to labs. If the prostate gets stimulated in any way, shape, or form, I've seen this with cyclists. The bike seat sits right there at the prostate. If you were to undergo a DRE, digital rectal exam, and then get your prostate, your PSA drawn, it's going to be elevated. So it's not perfect, and that's important to know. It really serves a better purpose for trending, not a one-off elevated measurement. And another thing, urinary symptoms. Many men worry about benign prostate hyperplasia, also known as BPH. While caution is warranted if you have severe symptoms, studies have shown that mild to moderate BPH is not a reason to avoid TRT. And finally, cancer risk. In men without prostate cancer, there is no credible evidence that physiologic testosterone replacement therapy triggers malignancy. Still, the key is monitoring, guys. You deserve to have vigilance and a close working partnership with your medical team. We are not practicing fear-based medicine. Your provider should be your best friend. You should be able to contact them with any questions you have, and they should be able to articulate a good response to give you the facts, but also reassure some of the concerns. Let's take a quick look under the microscope of prostate cancer. Prostate cancer is almost always what we call an adenocarcinoma. It arises from glandular cells in what we call the peripheral zone. It often starts quietly as precancerous changes called high-grade prostatic intraepithelial neoplasia, or PIN, but over time, genetically, it changes and things start to accumulate. Early cancers rely on androgens to grow, but as they evolve, they can survive even in low testosterone environments. And that's why advanced cancers often become castration resistant. And here's something most people don't know. Many prostate cancers grow so slowly, they will never take a man's life. You will die of other causes before you die of prostate cancer. There's still a balance of vigilance and perspective that we have to have in all of this. And so, where does that leave you? If you're considering testosterone replacement therapy, here are some essentially guiding principles that I recommend. Screen first. We check a PSA with all of our initial labs and every single follow-up lab. Because like I said earlier, trending is the most important factor regarding the PSA. Monitoring it on regular intervals.
Guys, if you like content like this, please like, follow, and share the Still City HRT and Weight Loss Facebook and Instagram page. Now back to the podcast.
We always get our first set of follow-up labs at 6 weeks, then 3 months, and at least every 6 months. But if someone was to come to me with unreassuring symptoms, we would get them right then and there. So make sure you're trending these numbers. And then, of course, the obvious, there are red flags. When we see drastic increases such as doubling of your PSA, or you should be seeing a primary care provider as well, if they're still doing DREs and they assess for nodules and they feel something abnormal, these are all red flags. These are all things that warrant specialists and further investigation. But most importantly, work with a clinician or a provider who understands the evolving science. As I've said before, testosterone is not a panacea, but it's not a villain either. When used responsibly, it can restore your energy. It can improve your metabolic health, your libido. It just supports well-being without putting your prostate at risk. So let's hit on some wrap-up points here. The fear that physiologic testosterone replacement therapy inevitably fuels prostate cancer is outdated. It's incorrect, and it should not be quoted in practice ever again. Modern studies and guidelines support safe use with proper monitoring. It's there, guys. I'm not making this stuff up. You deserve care that is grounded in evidence. Not fear, not speculation, but evidence. Your health journey, guys, is yours to lead, but you don't have to walk it alone. We're here for you.
Let's get real for a second. Yeah, aging happens, but feeling exhausted, struggling with sleep, losing your edge in the bedroom, and watching your confidence tank, that's not just getting older. That's a hormonal imbalance, and you don't have to live with it. They'll tell you hormones are dangerous, but hand you a prescription with a mile-long list of effects. Enough is enough, guys. At Still City HRT and Weight Loss, we cut through the noise. We offer safe, bioidentical hormone therapy customized to you and backed by real lab monitoring and personalized care. Because your health isn't one size fits all. If you're done with the BS and ready to feel like yourself again, strong, focused, and confident, call or text us at 719-669-4223. Let's build a plan that actually works for you. Still City HRT and Weight Loss. Be the hero of your own story.
All right, guys, welcome back to the question and answers. If you have any questions that you want answered, send them to hormoneshappen@stillcity-trt.com, and they may get asked on the podcast or a TikTok live. Jess, 29, male. I'm on TRT right now, and I have been having horrible nipple sensitivity. I really want to start a blocker, but I'm worried it will negatively affect my erections. Estradiol plays a huge role in erections, guys, if you didn't know that. Estradiol, the most prominent type of estrogen that's made in a male, may produce small amounts in the testes, small amounts in the adrenal glands, which sit on top of the kidneys, but a majority is actually aromatized or created from testosterone. And while it's criminalized, the reality is estradiol helps to protect our bones. It protects our heart, believe it or not. It's very anti-inflammatory. It regulates serotonin and dopamine in our brain. But we have estradiol receptors on the penis, guys. And when it's low, guess what? No erections. I've seen it time and time again. Now, for you, Jess, depending on how long you've had that nipple sensitivity and depending on your dosage, I'm not a huge advocate for blocking estradiol. I've made that known. But I am not so close-minded that I say no one should do it. Because there are populations of men out there that could benefit from it. There are individuals that aromatize at higher rates. They just genetically aromatize more testosterone to estradiol, and they have a very narrow testosterone to estradiol ratio, which is going to result in those symptoms that you're talking about. Adipose tissue, being overweight, aromatase, the enzyme that converts testosterone into estradiol, is stored in fat tissue. The more fat tissue you have, the more aromatization possibilities you have. And so for someone that is significantly overweight, just starting TRT, they may benefit from blocking that aromatization initially. Then as they start to lose weight, we don't need it anymore. I don't know your full situation, Jess, but if you were one of my patients, if I had a patient who'd been having these symptoms for a couple weeks, I would go ahead and start giving them small amounts of anastrozole. Not so much that we're going to cause that estradiol level to get really not even to within normal range. I like it to be elevated. I'm assuming your testosterone level is elevated too, but if we're not lowering it enough to have concerns regarding issues with bone density, cardiac protection, or your erections, it's okay to block it. I don't think a lot of guys need it. I'd say 90% of guys don't even need to think about it, but 10%, you got to do it. You got to individualize this stuff. Kyle, 44, male. I'm currently on BPC 157 for chronic knee pain, but I'm not noticing a difference. Should I be injecting it into the knee joint or the fat tissue around it? I'm going to say, Kyle, do not, and I'll repeat it again, do not inject that into your knee joint. Reason being is once you pierce that knee joint, if you're not using a sterile technique, you're not putting it into the right spot, because people are trained in this, you can do some damage. So I would never inject anything into the knee joint unless you're specially trained. So the fat tissue, yes, that's really where you're going to want to put that injectable peptide. I'm assuming it's injectable for the question. And you're just going to want to pinch up a little bit of fat skin around the area where it hurts the most and just inject it right in there. The closer to the area of pain, the better the effect. But absolutely do not put that thing into your knee joint. Sam, 34, female. I've been diagnosed with PCOS and have had no luck being able to get pregnant. I've heard that Ozempic can improve fertility in women with PCOS, but I do not really need to lose weight. Is this something I can still take? The GLP-1s like semaglutide, tirzepatide have been shown to help with fertility for a couple reasons. They support ovarian function, but they also help to reduce insulin resistance, which is the main complication from PCOS. We focus on the hirsutism, which is the facial hair, the acne, all of these androgen symptoms, but the reality is the insulin resistance that results from PCOS is the most dangerous aspect of it. And think about it, these GLP-1 medications were made originally for diabetes, which is caused by insulin resistance. And so when we're correcting the insulin resistance and ultimately improving your metabolic profile, you're going to improve your fertility. And at one point, they may still be calling it this Ozempic babies, where women were starting Ozempic for weight loss or maybe even diabetes, and they were now having children unexpectedly, I suppose. But the reality is yes, it can help, not just with PCOS, but anyone that's got some degree of insulin resistance or metabolic disease. Now, you not wanting to lose weight is completely fine in my book. I have plenty of patients who are within a normal healthy body weight who use these GLP-1s for metabolic health and just general longevity purposes. You don't have to take it with the goal of weight loss. I'm on tirzepatide, but I'm also hitting the gym trying to build muscle mass. So I think that it would be very beneficial for you, either semaglutide or tirzepatide. I recommend tirzepatide, and then eventually retatrutide's coming out. But yeah, I believe that could be very beneficial for you, Sam. Charles, 55, male. What's the deal with Cialis? I take it as prescribed, but it's not helping with erections. Should I try Viagra instead? This isn't an uncommon problem, Charles. When you talk about Cialis or even Viagra, these are phosphodiesterase inhibitors, essentially. And what they do is they block what's called phosphodiesterase, which is an enzyme that breaks down nitric oxide when it's in our blood vessels. And when our penis enlarges, it fills with blood in what's called the corpus cavernosum. And the nitric oxide is in there just doing its job, helping us with an erection, and the phosphodiesterase starts breaking it down. And when it breaks down that nitric oxide, guess what? Our erection's gone. So when we take an inhibitor, we're inhibiting its ability to do that. So the nitric oxide is there longer. Now, with that being said, if you're not getting good nitric oxide production to the penis, it doesn't matter if we're blocking phosphodiesterase. The nitric oxide's just not there. And it can be from a lot of things. Testosterone in and of itself helps to improve nitric oxide. Diet, exercise, it's very controversial, but using fluorinated toothpastes and most mouthwashes can actually destroy the bacteria that's in your mouth that helps to produce nitric oxide. So there are more reasons as to why that Cialis may not be working. And you also have to think about this too, Charles. If it's a blockage of some type, there's a blockage preventing the blood flow to the penis, you got to believe there's blockage somewhere else. I tell all my guys this. The erectile dysfunction is the canary in a cave, okay? It could be a sign of a bigger issue. That's something you may want to talk to your primary care about. I don't know your medical history, but you really want to make sure that that's not the case. But otherwise, like I said, Cialis is pointless if you're not getting good nitric oxide production. And the only difference between Cialis and Viagra is essentially the action of onset and the half-life. Rudy, 31, male. My doc wants to put me on Clomid for low T, but I've had friends who've been on it and it was a waste of time. Is it worth trying, or should I get some real tea from someone at the gym? Well, unless that guy at the gym is a provider, I would say no. But really, Clomid. So Clomid is a combination of two medications, zuclomiphene and enclomiphene. It's known as a selective estrogen receptor modulator. It tricks the brain into thinking your estrogen levels are low. And as men, we make a majority of our estrogen by converting it from testosterone. So the way our body responds to this misconception that we have low estrogen is that it makes more testosterone to be converted to estrogen. And so that's how we increase our testosterone with this type of medication. Now with Clomid specifically, having the two different isomers in there, the zuclomiphene and the enclomiphene, they both act on estrogen receptors differently. Enclomiphene antagonizes it, whereas zuclomiphene agonizes it. And the biggest issue is they have different half-lives. Zuclomiphene has a longer half-life. So what I've seen is irregularities in mood has been probably the biggest issue with Clomid, and poor effect. Now, if you were to take enclomiphene on its own, which is just the actual estrogen antagonist property, I've seen better effect with it. I've seen guys get their testosterones maybe 700-800 on enclomiphene. It's not great, but it's something. You know, depending on your levels and your symptoms, I honestly just recommend going right to testosterone. I don't necessarily believe we need to do clomiphene, HCG, testosterone. I really think that the safest, most straightforward, cost-effective way, go right to testosterone, guys. We're going to head that way anyway. I don't know anyone that's been on Clomid for more than a year or HCG for more than a year, monotherapy, without switching to testosterone.
That's a wrap on today's episode of Hormones Happen. I hope you're walking away with some clarity and confidence. If this resonated with you, let's keep the conversation going. Connect with us on Facebook, Instagram, or over on the blog. And if you haven't yet subscribed yet, go ahead. It's the easiest way to keep growing and learning. As always, we believe in your power to heal, thrive, and lead. Be the hero of your own story.